So today I want to tell you about two interesting things, which is the Duret hemorrhage and the Kernahan notch phenomenon. And the reason these are important syndromes to know about is because they can be supratentorial in origin, either iatrogenic or traumatic, and that means it could be a post-neurosurgical case, and they present with ocular motor findings. So when we have ocular motor findings, cranial nerves 3, 4, and 6, normally that implies that there's a brainstem problem. However, there are localizing and non-localizing, as well as false localizing ocular motor signs, and the prototypes for learning about these things are the Duret hemorrhage and the Kernahan's notch phenomenon. So if you have a lesion in your brain, and let's just say it's in the frontal lobe, normally the symptoms and the signs are going to be confined to that location in the frontal lobe. However, if you have transtentorial herniation, you can get compression of the brain stem. So even though the problem is way up here in the cortex, when there's mass, effect, and shift, the cranial nerves can be affected either from a hemorrhage in the brainstem. For example, if the herniation presses on the blood vessels, the perforating blood vessels from the basilar into the pons, you can get a pontine hemorrhage. Even though your problem was in the right frontal lobe, you might get a left 6 in the pons from a Duret hemorrhage. So a Duret hemorrhage is an infratentorial bleed from a supratentorial lesion causing transtentorial herniation and compression of the blood vessels that leads to the hemorrhage. And so those pontine signs from the oculomotor signs are horizontal problems. 6 nerve palsy, unilateral or bilateral. Internuclear ophthalmoplegia would be an adduction deficit rather than abduction deficit, or any combination of those things. Horizontal gaze palsy, which have different names, and you can watch the videos for that. 1.5 syndrome, Webino, the wall-eyed bilateral INO, or unilateral INO. So those are localizing signs, because the Duret hemorrhage is an infratentorial hemorrhage, even though the problem was supratentorial. So when we're confronted with ocular motor findings from supratentorial, it could be a real localizing hemorrhage in the pons or the midbrain called a Duret. The alternative is the transtentorial herniation occurs, and this is the tentorium. And when that happens, the third nerve can get compressed. So the tentorium is rigid dura. So even though the lesion is frontal, when the transtentorial herniation occurs, it could tilt the tentorium like this, and the nerve on the contralateral side can get trapped and compressed, producing a third nerve palsy. And so even though the lesion might be on the left side, it might produce a right third. So you'll think the lesion is in the right side when it really is on the left side. You'll think the lesion is in the infratentorial third nerve pathway, midbrain, vesicle, subarachnoid space, when in reality the lesion is a supratentorial hemorrhage or a supratentorial mass. And the Kernahan notch phenomenon is that compression from the transtentorial herniation. And that is a false localizing sign. It tells you not only the wrong location, it might be the wrong side. So it's falsely localizing and falsely lateralizing. And then finally, if you have a hemorrhage or a lesion that's large enough in your brain, you can get a 6th nerve palsy, and that can just be from increased intracranial pressure. As you know, the 6th nerve exits the pons, goes up the clivus, and then turns 90 degrees to enter into the cavernous sinus. But it's tethered at those two locations, the root exit zone in the pons and at the petroclival ligament in Dorello's canal. So because it's tethered at those two locations, elevation of intracranial pressure or a decrease in intracranial pressure, intracranial hypertension or intracranial hypotension, will stretch the cranial nerve 6 in that location, and that is a non-localizing sign of intracranial pressure, either too high or too low. So you should know about the Duret hemorrhage, a hemorrhage in your brainstem from perforators from the basilar in the infratentorial fossa from something that's going on in the supratentorial region, whether that's trauma, a hemorrhage, or neurosurgery. And the Kernahan's notch phenomenon, compression of the third from transtentorial herniation. That is a false localizing sign because it's telling you not only the wrong side, the wrong location, the lesion is actually supratentorial. Or a non-localizing finding. That's usually non-localizing sixth nerve from both intracranial hypertension or intracranial hypotension. Duret and Kernahan.